Pelvic pain in women accounts for 10 to 40% of all gynecologic visits. Most patients with gynecologic emergencies complain of pelvic pain, with or without vaginal bleeding. The first step in women of reproductive age is establishing pregnancy status. In pregnant women, of course, ectopic pregnancy and abnormal pregnancy is the main concern. This latter group will not be discussed in this lecture. What are the advantages of pelvic sonography in these patients? Well, both the transabdominal and the transvaginal approach can be valuable. We know about the lack of ionizing radiation and the fact that ultrasound is readily available and provides superior visualization of the female genital tract compared to CT. I like to think of pelvic sonography as a direct extension of the examining hands. By direct contact with the patient, she will guide you to the focus of pain. The origin of acute pelvic pain, defined as less than 1 month duration, in the non-pregnant patient may be gynecologic, such as PID, functional ovarian cysts, and others, gastrointestinal, most commonly acute appendicitis, abdominal wall hernia, Crohn's disease, or finally urologic, such as lower urinary tract infection and calculi. The objectives of this presentation are to familiarize the practicing radiologist with the entities most likely to be encountered from the emergency room, as well as to demonstrate the primary role of pelvic sonography in diagnosing these conditions. Here's an example of a recent case of a 30-year-old woman who was status post-gastric bypass and abdominoplasty. She presented with severe right lower quadrant pain and had a CT of the abdomen and pelvis. The orange arrow points to what was initially thought to represent either an inflamed Meckel's diverticulum or a stump appendicitis with an enhancing ring-like structure here, and she was taken to the operating room. Note the enhancing rim around a, quote, fluid collection. Here are some sagittal and coronal reconstructions of her CT scan, and again we see a rounded structure with an enhancing rim and a central fluid collection. Of course, we don't routinely ask patients when we do CT scans about their last menstrual period, but subsequently we found out that her LMP was 2 weeks ago. So the question arises, is the LMP relevant to correct interpretation? Let me repeat that. Is the LMP relevant to correct interpretation of a CT as it is in ultrasound? What was found at surgery? Note also a little bit of fluid in her cul-de-sac. Did we find stump appendicitis? Did we find Meckel's diverticulitis, a corpus luteum of the right ovary, or adnexal torsion? Well, the answer is a normal corpus luteum because her menstrual period was 2 weeks ago. So this patient had an unnecessary laparotomy because of failure to recognize a normal physiologic structure. An article published in the Journal of Computed-Assisted Tomography in 2004 served to describe the appearance of corpus lutea on CT and described a thick crenulated or hyperdense wall, usually less than 3 centimeters in diameter, associated with free fluid. The authors indicated that recognition of these CT findings should prevent misinterpretation or inappropriate management. Unfortunately, in this case, this was not prevented. One of the most common entities to present to the emergency room is acute pelvic inflammatory disease. This is an acute ascending infection of the uterus, fallopian tubes, ovaries, and pelvic peritoneum, usually caused by Neisseria gonorrhea, chlamydia, or co-infection with other bacteria. An important thing for the radiologist to realize is that this condition typically presents not mid-cycle like the corpus luteum, but during or after menses. The clinical manifestations are lower abdominal and pelvic pain, vaginal discharge, fever with or without nausea, vomiting, malaise, and a leukocytosis. On examination, the typical findings are bilateral adnexal tenderness, cervical motion tenderness, and a purulent cervical discharge. Well, what are the findings on pelvic sonography in acute PID? The early sonographic signs can be very subtle. Here we see a sagittal image of the uterus, and notice that there is an indistinct serosal surface of the uterus, just a tiny bit of fluid here anterior to the uterus and in the cul-de-sac. And an astute observer might see that there is some increased echogenicity of the pelvic fat due to the inflammation. The free pelvic fluid that contains typically low-level echoes actually represents some pus. One may also see endometrial fluid, and as seen here on this color Doppler image, an overall mild to moderate hyperemia of the uterus due to endometritis. If the disease progresses, we may see acute oophorytis, as manifested by slightly enlarged ovaries with multiple small follicles and an ill-defined outer margin. With further progression, we have acute salpingitis, in which there are swollen fallopian tubes with thickened mucosal folds, and the tube, which is normally not visible at all, is now readily visualized, but still separate from the ovary. So here is an example of a slightly enlarged ovary and a swollen edematous fallopian tube. Notice that the mucosal folds here are thickened and blunted, but we can still recognize the fallopian tube, here pointed to by blue arrows, as a distinct structure from the ovary. Very important to turn on the color Doppler, because before the tube is visible, we may still be able to pick up marked tubal hyperemia, and that is occasionally the only clue to an early salpingitis. As this disease progresses, the tube fills with inflammatory fluid or pus, and the distal end becomes obstructed. So with obstruction of the distal end, the fallopian tubes becomes more dilated, and it is seen as a thick-walled, pear-shaped structure filled with dependent low-level echoes. Occasionally one may see a fluid level. Here is the hyperemic fallopian tube in sagittal, and here it is in transverse. Again, to emphasize that using the color can be very helpful to detect hyperemia. And once we have a pyosalpinx, it may be very difficult to distinguish, to separate the ovary from the fallopian tube, and we use the term tubo-ovarian complex. There is also extensive posterior through transmission, which reflects the fluid content of the fallopian tube. Another example of acute salpingitis, here with a fluid level, thick-walled fallopian tube, perhaps more dependent pus, and some complex fluid in the non-dependent position. Another example of acute salpingitis with the cogwheel sign. These are the thickened, blunted mucosal folds, and here in another example, slightly more chronic, of the cogwheel sign. As the disease progresses, we may go on to frank tubo-ovarian abscess, which presents as a multilocular cystic adnexal mass, which typically abuts the posterior aspect of the uterus. So here in sagittal is the uterus, and here we have a multilocular pelvic mass extending into the cul-de-sac. Seen here in transverse, the uterus is displaced slightly to the left, and we have multiple locules of this complex adnexal mass. The complex fluid represents pus. Now, the large size of this cystic mass in comparison to the uterus is worthy of note, and notice that the mass is inseparable from the uterus. Acute PID could be confidently diagnosed in most cases by a gynecologist based on clinical and laboratory data. And imaging in that case would be reserved for patients who failed medical therapy in order to assess for tubo-ovarian abscess. However, in our current reality, many patients are referred by ER clinicians for an imaging study as an early diagnostic tool. and therefore failure to detect the subtle early sonographic findings may lead to additional imaging, unnecessary imaging with CT, and potentially to unnecessary surgery.